So the questions about methamphetamine or other drugs, let me just open it up to other drugs. So let's say marijuana, methamphetamine, benzodiazepines, blah, blah, blah. So the final common pathway for all addiction is this dopamine disturbance. It doesn't mean, however, that there aren't other aspects of the brain that are affected from this. So methamphetamine is like the purest focal dopamine piece. And we do find in 2 small, pretty poorly done studies that patients who happen to be on buprenorphine for the treatment of their opioid use disorder also significantly decrease their methamphetamine use. Now, I don't think they drew a good cause-effect pathway, so I don't know if it was the buprenorphine or just the fact that they were in treatment. And so I can't really say one or the other. We don't have medication for methamphetamine. The only thing that seems to work for methamphetamine is another addiction called contingency management, aka gambling. So contingency management is getting a reward for something positive. The most a basic example of contingency management is you have a negative negative urine drug screen, and because your drug screen was negative for methamphetamine, I'm going to give you a $10 gas card. Right? It's a pretty structured program. You do A, B happens. If however it's positive, not only do you not get a gas card, but I now have to see you more often. So that kind of positive and negative contingency management strategy is the most effective treatment for methamphetamine. In its most effective form, it looks exactly like gambling. Because what you set up is a program where they come in and they have a negative urine drugs study for methamphetamine, and then they get to go pull an envelope out. And inside the envelope may or may not be something of value. It may just give them an extra pull on that next time. Or maybe it's just a congratulations piece that says good job and nothing else. Interestingly, the possibility of getting something good is more effective than knowing you're going to get something good. And so contingency management optimizes that strategy. Now, how do we know that that works in this population? Well, they have addiction, which means that they're more susceptible to other addictions, such as things like gambling. But so we're using the known chemistry of the brain to help us. So methamphetamine, it's that, and it can work in a bunch of ways. It can be easy, like, you're negative for this, that was awesome, so you don't have to come and see me, we'll just do a telephone visit. 2 weeks, we'll give you some time off, or whatever is positive, reinforcement for that behavior. But there's anecdotal early evidence that low-dose buprenorphine may be helpful in boosting dopamine for that subset of the population. But the profound way in which methamphetamine affects that part of the brain, because it doesn't only cause the release of dopamine, it binds to the dopamine receptor. So it acts as a mimic of dopamine and a releaser of dopamine. So you get this release of dopamine and it stops the reuptake, so you get a whole bunch of it that goes there, but it also gives a direct impact. So you get this double whammy, and it causes a direct release of dopamine. So there's like 3 pathways. So methamphetamine, the 90% of it is the release of dopamine, causative release of dopamine. Then it also doesn't allow it to be reuptaken, so you get a higher concentration of it. But then it also, at high amounts, actually self-stimulates 2 subsets of the dopamine receptors. So it's like this 3, it's a small part, but it's all combined. That's tough. It's hitting the dopamine system from every angle at that point, and that's really problematic. But the same pathways occur. You still have a mother who, based on being pregnant, is now more motivated / naturally the brain is inclined to crank more dopamine out at that point, because we find a higher degree of motivation in a population of patients who are pregnant, right? For a lot of things, for changing diet, for watching fluid intake, all of these things seem to be easier to do during pregnancy, and part of that is because naturally you get a bump in your dopamine, but you also get a concomitant bump in oxytocin. But the short answer to your question is there's no good data to show that adding buprenorphine for methamphetamine is going to make a difference.
I've heard some research about thinking about supplanting the mother-child bond for the high of the drug. That therefore then having that baby and keeping them together can actually support sobriety.
Fully agree. Yeah, so the comment was very much around how once you have a baby, you basically get your dopamine bump from the interaction of the baby instead of the drug. And so it's the equivalent of, I guess it would be baby-assisted therapy. And so it basically, it's just you get this and then you get that little bump, and we do that. Now we all get that bump for a while, right? Mostly, until it's like the 6th night in a row and you're just like, I'm just kind of not there right now. There's a point of that. And so looking at that, that is a part of it. But what we don't want to do is have that fully supplant the issue, because if I was to dig a little deeper into the personality disordered side, it can create a dependent personality disorder that we don't need them to have. Because we need them to have that connection without it being a pathologic connection. And so we need to make sure that we're keeping an eye on some of these things. So the unintended consequence of making the baby be the reason they're well creates a little bit of a weird dynamic between mother and baby, which later down the road can create a dependent personality disordered interaction, which then, as we know, turns into significant enabling and then perpetuates some of the other negative behaviors that we would see in the kid that we don't want. So thinking longer term, it's a great addition, but it wears off because we know that moms actually have a higher risk of overdose down the road rather than early on. So it's only stimulating until, again, it's more poop and crying than it is happy and cooing. And then you get into that even ratio over time. But yeah, it can boost it. Oxytocin is helpful as well. And if you're breastfeeding, you get a bump of oxytocin a lot more than if you're bottle feeding. You even get oxytocin if you just bottle feed them while they're skin to skin. So you can still get oxytocin even through that. You don't have to be breastfeeding. But because there are some that just, I don't want them to feel like a failure if they can't. Like if they just fail to produce milk or things aren't working, have never a nipple, whatever the issue is. But you want to make sure that you have them understand that the act of holding them just like they are and feeding them in that same way, skin to skin and in that same capacity, can be very helpful in that. But it doesn't fully supplant that. Yeah.
Talk about stigma in pregnancy. What's your recommendations from training medical staff on trauma informed and educating us?
Yeah, so the question is about what are the recommendations about training your staff in trauma-informed care? So the cool thing is there's actually pretty good curricula that you can identify. There are a number of places that you can just pull down off the internet and get the basics. We built our own because I had like a wicked awesome group of therapists that were good at this and knew this, and they built it. The basics that you need to teach them though, so just starting from the tentative things you need to teach them, because they don't have to be deep in the theory of it, they just need to understand the practical implications. The practical implications are a look will kill, listening always works, and then if you feel uncomfortable, get out of the way. Those are the things that we basically gave them for that basic survival. So looks will kill, the eye roll, the smacking the lips, the, I mean that might as well, they're going to go use it in the parking lot. It is an immediate, that happened and then that happened. It is causative because they're coming in scared, fearful, shamed, and worried, and everybody needs to know how they interact with that mom becomes really, really important. Especially at the beginning, because interestingly, if that first person does it right, the next person can do it even a little less right and it still works. So if you build that buffer early, then their expectation is one of it being compliant with them as a person, and so they're more likely to overlook little things as you go on. So the more that you can stack that trauma-informed approach, the more likely they are to be okay. And it can make up for maybe that accidental wrong thing you said, or just a bad day you're having, because sometimes that just happens. Sometimes the empathy train has left the station. Right? It's Friday afternoon, you've stacked me with all these patients. They're all patients who are just a succubus of my own dopamine. And there's going to be a point at which you just kind of run out of the capacity to really heal someone at that point. Because you can barely hold on to yourself. There's just a reality to those things. And so in doing that, it's important to let people know when they have to call uncle. So it's not just about the training, it's also about the structure of the clinic. So we made sure that everybody was cross-trained in what the highest level of whatever their scope of practice is. So our MAs could cover the desk, Our front desk people, we could take blood pressures and stuff. We trained them on how to do those basics so they could do the paperwork for intake if we just had to kind of rotate them out. They also knew how to do scheduling for the next day, so that they just had to leave like human contact for a while and do that. We made sure that they could do that. We had our MAs were also cross-trained to answer the phone, so if the case manager just like totally tapped out, we gave them a scope of practice for what they could say. In fact, they became our most commonly used telephonic support, our medical assistants. In fact, the patients told them more than they ever told me anyway. Because by the time they got to me, I hold a prescription pad, and my MA, they'll come up and be like, "You don't want to write that today." And I'm like, "Well, what?" And they're like, "Well, this is happening to this boyfriend, and they got this." I mean, they just give me like the whole rundown. I just got like a whole Jerry Springer episode, from that like little interaction. But without that, I was just going to go about my day, and they would put on the face that they want to put on because I'm the prescriber. So once they're also a part of the team and you hold people to account, people are cool with this. They do a good job. I had to fire one person. It was our nurse. That I had to fire. She just couldn't flip the switch. She had 30 years of time in. She had the way that she did it. Wicked smart, capable case manager, leader of like administrator level person, really good. I thought that's what we needed, but she just couldn't turn off the internal to external filter. She just couldn't do that. And then when you can't do it, you can't do it. And you just let people know that this is probably not the right place for you because it's causing harm to patients. Which is a hard conversation to have because nobody, like I said, nobody wants to do that. But those are the big pieces. And even us as providers, we could tap out on patients. So if I saw a patient on the schedule that I just couldn't see today, just couldn't do it, I'm not going to be therapeutic for this patient, I can't do it, then I would rotate with my therapist. And so the therapist would go and see them. I would fill their prescription or whatever they were there for, unless there were catastrophic things, but then I would go and see whoever, do whatever they were going to do. And of course they would get like B-team therapy guy, to come in and do it instead of the therapist, but we would just chit chat, and I would at least be trauma informed and supportive. I'm not delivering, CBT. But at the end, it's as much about the training as it is about the system that you build to allow for that training to be consistent. And most of that has to do with kind of the self-care modality and letting people be a part of the team. That makes a huge difference. If you don't feel like you're a part of the team, you feel disconnected, and it feels okay to just be flippant. But if you know that what you do directly impacts the outcome of this person, people do a good job. They really do. And if they don't, they need to go somewhere else because they're probably very unhappy as well. But that's the general gestalt. There are a lot of online curricula that's good for it. What else? Yeah. Yeah, so the question is, does early childhood trauma change the brain in such a way that it makes them have a higher predilection for addiction? But then there was also a piece about the attachment disorder. So if I wanted to back up and get very neuropsych about this, addiction is an attachment disorder. I mean, that's ultimately at its core what it really is. It's an attachment disorder where you are overtly attached to something that's causing you harm, and it's disordered because you're unable to change it. And that again has to do with changes of the orbitofrontal cortex, the lateral habenula, the connection with the frontal lobe, and the nucleus accumbens, which is a little different than a human attachment disorder because it doesn't include, it still includes all of those that I mentioned, but it doesn't include the central bed nuclei of the amygdala. So they're really closely overlapped from just a standard attachment disorder. Most attachment disorders, Freud was pretty right on this piece, is that most attachment disorders actually do occur early in life because that's when you learn the basics of attachment. So early, high-intensity attachment is required in order for you to figure out what moderated attachment is. If you don't get early, high-intensity attachment, you're never going to have it. Or you're not going to know what it looks like and you're going to overdo it later. Because what it is it's about modulating your reward system and figuring out how much reward do I want to get from this attachment. And if you never learned it, you may be way under-attached or way over-attached. And so the data about the dopamine receptor bed is, yes, you do find that you get less reward if you had early lack of attachment neglect. This is why neglect is the most significant of traumas, even worse than sexual trauma, or that as far as like outcomes and risk. Because if you had the wire monkey mommy, for those that follow in psychology, you know, those studies that they did where you had carpet monkey mommy, if you had a baby monkey that had a carpet mommy, they did better because they felt attached. But if you had a wire monkey mommy, you didn't, and you were disordered, you were always in fights in the cages, and you did poorly, you aged prematurely. Even your telomeric length, the length of how so age is kind of a bad construct nowadays because it's not about how many years you've been alive, it's how many telomeres you've cleaved off of your DNA. And so they were older faster, and we've all seen that in this population, how they get older faster. You know, I'm 47, and I'll see somebody who says they're 47, and I'm like, man, we don't look alike. Like, I feel pretty comfortable at 47. I got aches and pains, but I see somebody and he's like, I'm 44, and I'm like, oh my God, I don't know what happened. It's like, in dog years? I don't know, this is crazy. Like, I mean, we've all had that, but this happens with stress and cortisol and things like that. So when you don't have good early attachment, you also produce higher amounts of cortisol because you feel like you don't have support, so you're in fight or flight more often because you can't relax. So that increases cortisol, which increases the way you metabolize food, which increases ghrelin, which changes the way that we see food and take. I mean, there's just so many pathways that go with it. So the dopamine bed, yes, there's good signs for that, but again, it's a tiny piece of the entire picture. But attachment disorder thinking, and there's some people that have done amazing lectures on this. And before we finish this, I'll remember the name of the one that I had seen. They gave this best attachment disorder and addiction lecture I've ever seen. He's a LCSW in Missouri. But so as we talk about it, yes. So very true. But attachment disorder is a common theme throughout all of this. And if you just take, sometimes if you can't really understand the motivation of a person, if you step back and look at it from an attachment lens, a lot of times it kind of opens up kind of what's happening in that moment. Because you also don't want them to over-attach to your clinic, which we had issues with that as well.
As a mechanism for getting people off of amphetamines in the sense that oftentimes people on amphetamines say, well, I have ADD, so I need amphetamines to help me focus. And I use Strattera with kind of success, or am I just making it up?
Yeah, so the studies for Strattera or straight up dextroamphetamine or any of the other amphetamine analogs that work specifically on the brain. So we looked. It has been looked at a number of capacities, and it doesn't seem at the population level to be helpful at 1 year. It's placebo equivalent at 1 year for the six studies that have been done looking at different versions and different dosing regimens. In order to get somebody to not go find methamphetamine, they have to basically take dextroamphetamine at the same basic dose they were taking methamphetamine. So you have to basically induce the same level of intoxication, which is one of the problems with, I talk about how dopamine goes down and down and down and down and down to where the best day ever is now maybe 40 for some of these patients who have depleted their dopamine. The caveat here is methamphetamine. It will always squeeze more than 100 out of your brain. It will always find a way to do it, which is why it causes longer term damage, because the brain will rapidly try to lock down as much as it can, which is why when we remove methamphetamine out of the system, the withdrawal syndrome for methamphetamine is I'm going to sleep for a week, because there's just nothing left that's been produced because they've been pushing on that. So methamphetamine is its own animal. It still follows the confines and diagnostic structure of addiction, but it really is, it's really tough. This one's difficult. So methamphetamine addiction, the only way that I've seen that people are consistently successful at a high level is to physically remove that person from their current environment, put them in another environment in deep therapy and treatment, which we can't do at a population scale. So we have to figure out, we're just not there yet. We're failing at that one. It is the next one coming. And so figuring out how we get there is going to be really important.
I was just going to say, along with that, we've had several methamphetamine patients who came in who had just gotten high and we didn't have a baby, and they were out of life from nothing because they didn't really bond with their baby. You know, it's still big skin as long as the nurse was there with that baby and all the time, but there was just some connection there because she was coming out, and it's just tough.
It is. So this is one of those that you have to literally poke and prod. So we would put them in. So we would this is like a terrible story, but so we had a mom that was the same way, and it was a bummer because she had done so well, but then she had a really bad interaction with the father of the baby right before she was ready to deliver. She didn't fully relapse into addiction, but she used for 2 or 3 days, and then showed up and had the same thing. So she got off, and even after 2 or 3 days, you can have a pretty significant, kind of hangover withdrawal effect from that. And so I wanted her so badly to have this moment because we had so many discussions about she couldn't wait, she wanted to have this moment, she wanted to be with her kid. She was on buprenorphine as well, so the kid had a mild amount of NAS and she was in the hospital. And so we literally put her in a wheelchair, pushed her to the NICU, put her in the little bench in the room where moms could be, and I tied a sheet around her chest onto the back of the thing because she kept kind of nodding out. And it wasn't because of being over-medicated, it was purely the withdrawal effect. And then we sat there and held her kid with her, and my nurse helped her breastfeed. So it was, you have to be really active in those situations. And it seems weird, right? You're like, well, if you're not going to think this is important, people go to that place where somehow this mom thinks that somehow this isn't important. I mean, it's just not the case. And so for that person, I mean, you really have to be, hey, wake up, come on, we can do this. You're doing good, we're almost there. I mean, you have to just be really kind of pushing in that. And what we found, honestly, is that by itself helped her to push past that withdrawal syndrome and got to the point where she was able to tame her eye. And so that took a Herculean effort. I had some words with the NICU doc. He disagreed with our pathway. I disagreed with his pathway. We were both chiefs of our division, so we had egos abound. And so we had a good, nerdy, academic, loud conversation somewhere. But because I had the most important people in the hospital on my side, I won. The nurses. So we all knew how that came out, but we all know who runs that show. So anyway, that's where we are. I mean, and sometimes it just won't work and it sucks. But what we do is we would create an appointment afterwards where we would come in and we would almost recreate the situation. We would bring them in and we would kind of start over. We'd see them, we'd put them in IOP, intensive outpatient, and we would make that a part of their IOP, which is that reconnection of breastfeeding. You got about a good 7 to 10 days to kind of still get some of that same boost and connection and all of that. But if you miss that 10-day window, it starts to deplete the amount of oxytocin because you're milking, you're having milk letdown, you're having all of these things that are occurring. And even if you're pumping and doing those things, it doesn't seem to give you the same pathway as the other. So good question. All right, so I want to lead into what we're going to talk about for the rest of the time, and that's going to be up to you guys. So, I think I've hit all the objectives that we had. I've talked about MAT, we've walked through each of the drugs, we've talked about outcome studies. I can dig in more on that. We can talk about marijuana, we can talk about adolescence. It's kind of a short talk, there's not a lot of research. Talk about co-occurring, what do you do with patients who have significant co-occurring? Because we've talked about trauma and addiction, but I don't think we've really hit the co-occurring area that I've seen. We can talk about revenue cycle, we can talk about, cash burn ratios, payment modalities, whatever. There's a little bit of stump the chump, so bring on the hard stuff. This is going to be super fun. Yeah. Great, so I'm happy to talk about cannabis. I know we had earlier, you talked a little bit about it as far as the pain syndrome goes, and so I'll move into more of the kind of addiction and behavioral health side of it. I'm happy to talk about that. All right, so we got one.
Can I expand on that and ask a specific question?
Sure.
If you have a long-term cannabis use for 10, 15 years, does that affect your ability to create dopamine the same way a 10 or 15-year user of heroin?
So the question is if you had used marijuana for 10 or 15 years, does it deplete your dopamine in the same way in which heroin does? The short answer is not as profoundly, but in parallel. So it does go down, it does deplete it, it is trackable, and it does induce craving when removed, and induces the behaviors associated with addiction. So while it is not as profound as opioids long-term at a density, it's there. It's equivalent to alcohol. So that's, if we look at the dopamine depletion and long-term effects of craving and outcomes, it's equivalent to alcohol, and it's 12 to 17% of people who use marijuana consistently will become addicted, which is the exact same thing as we see in alcohol. And I'll dig in a little more on that, what that means there, because marijuana is not really anything. It's a whole bunch of things, so we'll talk specifically about which of the compounds are the ones that are causative to that, and dig in a little more.
Is this something you address is the
All right, great, yeah.
And then also, when, I just like to hear some of your experiences with when NAT wasn't right, and despite all of the efforts, it really was not right. We don't have
Right.
when is it time to say this is the right thing?
Right, so one is address length of use of medication-assisted treatment, and the other one is how do you know when you're kind of done trying it, when it's just failing? Yeah, I can definitely speak to that. Let's take one more and then we'll have another round after that. Co-occurring, all right. So let's start with marijuana. I mean, it's the elephant in the room. It's especially the elephant in the room of California. And Northern California specifically. And it's, so I'll start with a couple of statistics because I think we're going to move back to the data science and math of this. For the last 10 years, the #1 cause of admission for addiction treatment for adolescents was marijuana use disorder. It's for the last decade. It's not even really legal yet. It just became legal in a couple of places. Anytime that we've legalized the substance that made it ubiquitously available, we have always seen an increase in the adolescent utilization of said substance because we've just made it more available. Increased availability means increased probable utilization. Increased availability, quote, legality, also decreases the perception of harm by those that might try it for the first time. So if we look at the NSDA, the National Drug Use Survey for Health, which I don't talk about much because it doesn't include incarcerated or homeless populations, so I think it's not very accurate for most of the populations I treat, but it gives trends. And when we look at the trends for this subset, what we identify is that the perceived risk of harm from marijuana is the lowest it's ever been in the adolescent population. So this is problematic because that always is followed by a trend line that shows a significant increase in those that have a substance use disorder to whatever substance they feel is not harmful. We've seen it for opioids, we've seen it for tobacco, we've seen it for alcohol, all of those have happened, cocaine, stimulants, all of those have done that. The trend line always follows. If we could only have economics that follow those very predictable trend lines, it would be great, but we can't. So marijuana is also decreases long-term if you start in adolescence and use on average 3 or more times per week. And I know most people who smoke weed as an adolescent aren't like, one Saturday a month. Most people are smoking weed, or vaping or waxing, whatever formulation that they want to use. And it's a lot more than 3 times a week, generally speaking. But minimum 3 times a week or more. What we've identified is that if you do that for 2 years, then you permanently decrease your IQ by 10 points. So this was an initial European cohort data which was really questioned for causation. So we looked at it to determine whether or not we could really say that it was cause and effect. So they spent a lot of time teasing out the data and then recollecting and prospectively tracking the data. It seems to be true. And so this is a bummer. They took out all other drug use, they took out parenteral drug use, they took out tobacco, they took out all of these other indicators of trauma, all of those things got removed, and they isolated as best you can in any large-scale population study the utilization of marijuana greater than 3 days, and it decreased the long-term acting IQ by 10 points. So what does 10 points mean in an IQ? About $50,000 a year for the rest of your life. So it is the difference between an associate's degree and a PhD on average. So it is an important 10 points. And we all have the person that we know that, I got a friend, he smoked weed all the time, he did fine. He would have done more fine. Because some people can give up 10 points of IQ, but there are many days in which I need every single point that is available to me. And so that's one thing, and that's a bummer. That scares me. I have a 7 and a 9-year-old. I mean, I'm really struggling with, what we're going to do, so I figured I'm just going to fix the whole system in the country, and then by that time we'll be all right. But the problem is we're running out of time. But I gotta hurry because they start using now at like 10. So I think I'm just gonna move to an island, right? You know, I guess I would have to win the lottery and have 2% body fat. But as we start to look at this, marijuana is also different. They say, well, so some of the fallacious arguments. So you hear a lot of times in arguments about these different things, what we call a straw man argument. So this is a logic term that talks about if I make a statement that says marijuana is addictive as a substance and can cause harm to an individual, then I will have somebody say it's not as harmful as alcohol. It doesn't negate this argument. And the answer is that's actually incorrect. It depends on how much alcohol you drink. Because if you have a bourbon every now and then, there's really no harm. We can't identify harm except for an increase in lower esophageal cancer and an increase in stomach cancer, which is a known 2% increase in risk over a lifetime. And that's with just a few drinks in a week, right? The more you drink, the more likely it is to cause harm. The most likely harm that it causes, actually, is impairment and falls more so than any other chronic disease that occurs. But at the same time, you know, if we're really going to look at it, if I wanted to break that down to another argument, it's like saying, alcohol is like a 45 caliber bullet, and marijuana is like a 22 caliber bullet. I am pretty sure I don't want to get shot by either, because they can both kill you. And so we need to just have an open, honest conversation about this, because it's on its way to becoming legal federally. It's going to happen because there's billions of dollars in DC pushing it, and we have measly hundreds of thousands of dollars pushing against it. So we're allowing tobacco to happen again. So I'm already taking notes on what everybody's saying on their billboards and who's saying it and who's producing it and that. So in 15 years, when we have another thing like the opioid settlement, I will be the star witness and I will crush them. Because I don't care that we make it legal as a country. I just want us to have a truthful conversation about it so people can really have an appropriate understanding of risk. Because right now, we're creating hyperbole and we're creating myths and we're being really dangerous with the way that this is rolling out. I pulled out of LAX the other day. There's a billboard right on the exit that says marijuana decreases deaths from opioids by 30%. That's just not true. What they're looking at is the data from Colorado that saw a decrease in the overdose death rate in the years after they legalized marijuana. What else did they do in those times? The highest number of naloxone distribution points per population in the country. They quintupled access to medication-assisted treatment, and they mandated screening and MAT at all the residential programs. That might have also had something to do with it. So the problem is that people will see that on a billboard and they'll start to think that, especially if you're in the industry. If you're in the industry, you're going to see this and you're going to say, what I'm doing is good, without really talking to yourself about the possible harm. This happened in tobacco. How many white coats with stethoscopes like menthols or kick-ass? I mean, that was like a part of the strategy of people talking about this. And then when you have someone like Sanjay Gupta, you know, who puts on a special called Weed and then just puts out lies, it was weird. It was surreal as an addiction medicine neurobiologist, doctor, watching that and watching him say things that were wholly scientifically inaccurate. Because weed does not treat seizures. Cannabidiol treats seizures. There are 87 psychoactive compounds in marijuana. How much is in each, what bud you buy? Who knows? Not the people selling it, even though they tell you, because we've studied that. They randomly went to 15 places in 7 different cities to buy, medicinal marijuana, the stuff that's supposed to be helpful to people, just to determine how medically stable it was. And they say it's this percentage of that. Less than 5% of the time, it was within 15 percentage points. Meaning, it was way off. None of those would have passed any accuracy test associated with any other pharmaceutical in any other place on the planet. Not just the US FDA. they would not actually have passed the Honduran FDA. Not even close. So we just need to make sure that we understand what's being said doesn't necessarily match what we actually know. We've had 20,000 publications on marijuana since 1990. It's not that it's not studied. We do have more things that we want to learn about it. But it's actually some of the things that we want to learn have been studied and found to be harmful. So what we don't want to do is something unethical, like create a harmful research study that we know we may be causing harm because we have data to show it. So if we walk through a little bit, I'm only going to spend 5 more minutes on this because I want to talk about other stuff too, but in the studies that look at chemo-induced nausea, they try to do a really large, randomly controlled trial for this at multiple sites and do a solid, robust study on it. They could not keep people in the study because those that were randomized to the THC arm didn't have enough relief, and they got better relief with the other stuff, so they voluntarily dropped out of the study so that they could get another drug to help them. So they actually couldn't recruit enough people to stay in the study to get an endpoint because it wasn't as helpful as Zofran. And we know the side effect profile for Zofran or ondansetron is pretty low. So if we look at it for chronic pain, the only 2 types of pain that it's been shown to be effective for longer than 3 weeks is neuropathic pain from HIV and neuropathic pain from MS. It seems to be pretty helpful in that subset of pain, very specifically neuropathic, and very specifically causative of that, because just peripheral neuropathy from vascular neuropathy, it doesn't seem to be helpful. The interesting thing is the percentage of THC that was the most helpful in all of those studies was 6%. It didn't help at 3%, it helped at 6%, and made it worse at 9%. Yet what are we giving people for this? Like 27%. So there's a set of papers that were developed by the Northern California Growers Association for marijuana as their strategic plan for rolling out the legalization of marijuana over time. And it started with identifying those states that very specifically had voter-capable initiatives that they could put on, that if you sign enough people up, you could get it on a ballot. And so they went to those states, they spent millions of dollars in each of those states and got it on for medical marijuana through that pathway. If you notice, the vast majority of none of the states that don't have that pathway, the voter ballot initiative pathway, none of those states have legalized marijuana. It was only the states in which you could have voter-approved marijuana come in. So I don't even use the term medical marijuana, just say voter-approved marijuana. But so when we look at it, that was their plan, because once they make it medical, then we get a decrease in the sense of harm, which then makes it easier to push for legalization. So their strategic plan has worked. So we just need to understand that there's 87 chemicals. THC is only harmful. I can't find one study that shows that it does anything good for anybody past 3 weeks. Alcohol works longer for pain. There were studies for alcohol that were at least 7 weeks long that showed that it helped for pain for 7 weeks before it started to have more side effects than it did positive impact. Cannabidiol, however, probably is going to completely change the way we treat a subset of diseases. Cannabidiol is a medication, one of the chemicals in there, it's the second most, CBD, and that actually has really good early data for decreasing craving and addiction. It has really good early data for depression treatment. Yeah, and it actually has good data for additive therapy for pain treatment. So, and it was talked about earlier, the ratios, and we talked about the CBD to THC ratio, that if you have a high CBD ratio, it seems to limit the side effects of THC. The problem is that the marijuana plant has to make a decision. It has to make a decision, do I make a lot of THC or a lot of CBD? It can't make a lot of both. So as you preferentially breed plants to have a high amount of THC, it has to decrease the amount of cannabidiol. So when you have 27, 32% THC, you end up with less than like 1% CBD. That marijuana increases chronic anxiety. That marijuana increases suicidality. That marijuana increases nausea. It actually causes marijuana-induced gastroparesis, which we call hyperemesis syndrome, which I've seen a lot of now in the emergency department when people come in, I can't stop throwing up and I'm trying to take marijuana for it, it just seems to get worse. And I'm like, well, you have to stop marijuana and it just goes away. Oh my God, no. I won't even think about that. Well, that's screening, assessment, and level of care. I mean, that's just like, we figured this out, right? But at the same time, we have to really think about how we're talking about this. If somebody wants to go smoke weed on the weekend, I don't care. I could care less. I smoked weed in college. It just gave me dry mouth, made me laugh, and look for Doritos. It really didn't do much else. But at the same time, it's not my job to get into other people's world on this stuff. I just think that we have to make sure that we're honest. And we're not currently being honest. And lawmakers are really guilty for this, just like they were for tobacco, because they're like, if we just put it out there, we can tax it and make money. But I will tell you, the studies that have looked at the cost of the increase in the addiction that is identified when you expand the use of marijuana costs more than any tax you're going to bring in. So we will need more help. And the problem is that we also quintuple the need for psychological treatment, which is going to roll me into the co-occurring conversation, is it increases the chance for acute psychosis and permanent psychotic disorder in adolescence by 20 times. Not 20%. There is a 20 times increase that if you have a genetic predisposition for schizophrenia, schizoaffective disorder, which is all about decreased changes in arborization, which is branching and connections of nerves and hippocampus. That's a whole other piece. But when we look at that, we know that it increases psychotic disorders in adolescents who use it on a consistent basis. We can't even treat the current population of people with a psychotic disorder to any level of adequacy, at least that we feel comfortable with, and we're about to get crushed with it. So what I will leave you with marijuana is that opioids have a huge mortality issue. Marijuana will have a huge morbidity issue. One of which is sad and horrible and frustrating because so many young people are dying. And one is sad and frustrating and angry because so many people will not grow up to be the person they wanted to be. And we will be stuck with the psychosis, and we will be stuck with the depression and the anxiety left over from the misinformation that's currently going out. And so we better get ready for that. Because that message that I am talking about, which is backed up by hundreds of publications, not reading the High Times or Arrowhead or watching CNN. I mean, this is the research that we look at. Is not, how many people have heard most of that? Probably not much, right? I mean, some people in here have heard it, but even people who work in this field are like, oh, really? So that message is not going to get out. The message that's getting out is it's the next best thing. We're making grandma suffer at their end of life, and all those things. Yeah. Yep. Yeah, so the study on veterans with use of cannabis for PTSD. The short answer is that it seemed to be helpful for short term. However, they actually added on the diagnosis of addiction in almost 40% of the patients because the amount required to decrease the PTSD was so high that it basically induced iatrogenically, meaning we caused it, addiction. And then the effects all wore off, and then they ended up with more panic-based disorder on the other side, and it also messed up with their sleep cycle to the point where they were having less sleep, which equals more psychotic disorders, which equals all of these other things. So unfortunately, I mean, I would love it if it just worked. That would be awesome. I mean, I have no emotional connection to any of this other than what does the data say and what is the truth that we can understand to make these decisions. I don't care. The decision for that, unfortunately, it didn't work. But there was the little chunks of data that got out. So then we create the common, telephone game of it's the best thing that ever worked, and they're just keeping it under wraps because they want to keep these people in treatment and don't want to get, then we get down into the conspiracy theory territory on some of this. No, it's just that it didn't really work, and that sucks. Maybe one of the components will, but we haven't broken it out enough to determine if the other 83 components are going to be helpful or not. Yeah, so this is a great question, and this goes to a bigger issue, but the question is really much, you're an addiction counselor, and you don't know this stuff, so it's hard, this stuff isn't in the normal training pathways. It's not in the normal onboarding of getting a license to do this. And so when they ask questions, it's hard to reply when they bring you something and you don't have a stack of literature next to you that you can pull from to say that it's not this. And because there's so many untruths, even if you did know it, it's really hard for you to get that message across in a trustful way. I mean, that's one of the other things is, I can do it because I'm in this weird innate position of power, right? I'm a white male doctor in America, which gives me power I probably shouldn't even have innately. But honestly, I mean, you just walk into a room, and because I have those traits, which I had mostly nothing to do with, I just show up and I get to do these things. It takes probably a bunch of me actually speaking up in the halls of Congress and in the FDA and in places of power to actually be able to undo some of these things, at least in the way that the current world works. Otherwise, it's just people screaming from the bleachers, and it gets really frustrating. But what we can do is we can eliminate a lot of this issue with knowledge, and we are building out a learning management system that was funded by NIDA as well as RWJF, so that we can at least get everybody to have a basic understanding of this. And we're building that now. We have about 30 hours of stuff on there, and that should be available to you guys in the fall. And it's not just overviews, it's got short overviews, but then we've built archetypal patients. And we talk about them in adolescence, early adult, and late adult. So it's not just one age or one general patient. We talk about Kayla. We talk about exactly what happened to Kayla in her early life. And then she's pregnant. What do we do? We talk about Tobin and when he got arrested and how we work with this. Or Gloria and her headaches and how her co-occurring disorder does that. So that'll be available. It's coming. It's a lot of stuff. It's like 1,100 separate little videos. And it's a lot of stuff. But we're building it out because you have to know it. But I also want some place that patients can feel comfortable getting information. And I would love to say go to the NIDA website, but it's crappy. It's a terrible website. The information's amazing, but it's just poorly designed. It's lowest bidder stuff, so it makes it tough.
Where does the average person go? Where do they go?
You're here.
You weren't employed in the medical industry.
Yeah, so I would say drugabuse.gov is the place where you can find a lot of really good information. You gotta hunt for it. It's not that easy to see, but it's written in a way that most people can understand it. It's very pragmatic. It's not one-sided. It's the same kind of discussion that we're having here today. I'm not making a moral judgment about you. I'm just explaining what the data shows. So drugabuse.gov is probably the best. American Society of Addiction Medicine has some patient-facing stuff, but not much. It has a lot of provider-facing stuff. PCSSMAT.org has a bunch of provider-facing stuff that's funded by the federal government. That's pretty middle of the road. It's a little tainted with a couple of the lectures from people who get a lot of money from some of these drug companies. And I'm given lectures that are sitting on there. I've reviewed almost every one of those lectures. But at the same time, like everything that you absorb, ask questions. Trust it, kind of. I expect you to trust me 85%. And the other 15%, you got to check for yourself and make sure that you're looking at it and do it now. Yeah. Marijuana and pregnancy. So marijuana and pregnancy is, the data shows that if you're smoking marijuana during pregnancy, that you do have untoward effects on the fetus, and they are long-term. So it does seem to increase the behavioral disorder child, and that generally speaking is attentive disorder, so ADD, ADHD, and also mood disorders later in life. Learning disabilities seem to be linked, but I don't find literature that makes me know causative relationships. And those are the things that come. It doesn't seem to mess with birth weight. It doesn't seem to create like a cleft palate or a thing like that. But it does seem to have a change in the mood disorder and the ability to achieve at grade level. And they've looked at that now up till 12 years, and it seems to be not below and staying steady. It seems to kind of continue down over time. So the trend is not that you parent, you're just lower, but you stay with everybody. The trend is you're lower, and then you level out at a much lower space where other people go up. So that's really disheartening, especially since there are people talking about smoking weed for nausea and pregnancy. So this is the thing that angers me about the medical marijuana industry the most. They're not accountable. If I said stupid shit like that as a doctor, people sue me. I mean, honestly, I have to be accountable. I have to carry malpractice insurance. So if I screw up or I say something wrong that causes harm, I'm held accountable. they are not held accountable, and that's not okay. They're just like, whatever, dude, Orange Kush is fine. And I can't, and there's no recourse when baby comes out wrong at 12 and they're pissed and they're frustrated because now they have all this other cost and frustration and anger. That person's not accountable. And so this is where that's why it's voter approved marijuana, not medical marijuana, because the checks and balances aren't there. You know, if I do something wrong, if I make a wrong decision as a doctor, I have to be held accountable for that. That is a part of the relationship we have with the patient. Is that if I make a wrong decision and I go outside of the standard of care, we have malpractice because you deserve some remuneration for that. You deserve something back for that. But there is none of that accountability in this the quote medical marijuana field, and that frustrates me. Because as we get to the point where we have pregnant patients hearing something and they're scared, it sucks. I can't even imagine having hyperemesis. I mean, I hate throwing up. You know, but I mean, they're just in there and just throwing up and throwing up. And if somebody's like, if you eat sand, I swear it'll make you feel better. They're just gonna eat a handful of sand because it's like horrible. And so people are throwing this at them and they do it and it doesn't make a difference, but they may sleep a little more so they throw up a little less. You know, and so they misinterpret that as causative for decreasing nausea, but there are no studies that show that that's the case. And we know it causes harm during pregnancy, so it's the equivalent of saying, I got some thalidomide for you, it's pretty sweet. It'll really help your nausea. We don't do that. So we have to just be cognizant of causing harm and really start to hold people accountable in the community. So we have dispensaries in Ann Arbor, and I've seen them put out some stuff in the paper, and I drove down and I was like, this is bullshit, and you can't put this in the newspaper. I mean, you have to, as a medical provider, you have to push back in your community. You can't tiptoe around this stuff. You have to have ownership of safety for your community and your kids. And yet sometimes you have to be a little bit loud.
So let's say a mother's taking that
Yeah.
with withdrawals, what are the long-term effects of
Yeah, so the outcome of the untoward effects of using methamphetamine during pregnancy, what does that do to the baby? Well, first, generally speaking, you are delivered at lower birth weight early. That's the general. You also have a higher percentage chance of placenta acreta, where you get it basically peels off the uterus and you get hypoxic and have these issues as it comes out. But the other piece is that we do see learning disabilities early, pretty significant behavioral disabilities that seem to mimic spectrum disorders. And that's for heavy, consistent use. Interestingly, it's for meth only, it's not for cocaine. Cocaine doesn't seem to, that whole crack baby thing is just, we found was not true. And most of the things that we were found in cause were just nutrition related and not cocaine related. But methamphetamine seems to have a longer term causative relationship. Now, the withdrawal syndrome doesn't look like neonatal abstinence syndrome. It's an absence syndrome, meaning that they're quiet. Like, oh, it's a super quiet baby. Like, that's because he's got like no dopamine in the brain. Because dopamine is not only, for reward, it's also epinephrine. I mean, it gets broken in and turned into epinephrine, so it is adrenaline. So it's the chemical in the body that actually is responsible for that. And when you take methamphetamine, it's not only messing with the brain, it's messing with the adrenal glands and other places. So you get atonal kids, you get a lot of changes in muscle tone, you get a lot of changes in when they can sit up, and these are things that can happen. I haven't seen a great longitudinal study on this yet. Sadly, it won't be long because we now have a high enough number of people that we're going to be able to track it and probably get data that helps us from a statistical standpoint. But that's, we're having to derive some of it from some of the countries that have these other issues, but they just don't have the tracking capacity that we have. And Europe's never really had the massive methamphetamine issue that we're having, and have had in the past.
So I've been kind of surprised at the permissiveness of parents whose kids are chronic marijuana users. And I think back in the day, when in our generation, if you smoked marijuana, your parents didn't know about it. So you couldn't use it that much. But now I have several kids who come in just stoned out of their minds at 15, and the mom's like, she smokes dope every day, but, she's good at school. I mean, what? And I feel like a parent, I don't know, and I'd be interested in what probation has to say. Like, what message can you give the parent that while I don't want to alienate them and make them say, like, you're a bad parent, but I also want to make it clear that this is not a good idea. Like, where is that?
Right. So one, it's condoning an illegal behavior. I mean, for one. So if we just start within the legal realm, it's probably neglect. And depending on how pervasive the parent is in obtaining it for them, it could very well be causative of harm. So those are things you have to think about. Generally speaking, those parents deal and or use consistently. But the other pathway that parents will get is this feeling of, thank God it's not heroin. And so they'll get that same 22 caliber, 45 caliber argument in their brain, thinking that, well, at least it's only weed.
Right, this is that.
Right, or at least it's under, we see all this with alcohol too. I remember in my high school, we had some of those parents who they would have a party at their kid, you'd show up and it'd be like a keg, right? And we're all like, sweet. And, but it's like a bunch of kids drinking out of a keg who are like 14 and 15. And we know that that's illegal and it should be, but in certain locations and cultures and pathways, it's seen as early. But it's at a point now where if that's occurring, one, they need information, but two, sometimes they need intervention. The kids definitely do, because if they're smoking weed every day, they're not doing well at school. And even if they get a good grade because they finish their homework, which I doubt, then at the end of it, they're not remembering most of this because it actually affects learning access and it actually affects the emotional learning access, which means you're not onboarding that normal therapeutic attachment piece as you go. So we're going to have some disordered stuff that we have to deal with from a kid's side, but that's definitely not great. Which gets us to kind of the disordered thought processes that we have to deal with from a co-occurring side, right? So let's say, what do you do with a person who comes in and has a generalized anxiety disorder with panic, and they say, I use my opioids to keep me from going into panic, and I've been on benzodiazepines for the last 5 years. It's pretty common. I mean, it's pretty common. Oh, and I smoke weed for breakthrough. So they're on opioids, marijuana, and benzos. And so here's the data on this. Opioids can decrease anxiety for the short term, but then as you build tolerance, it stops to be effective. But they decrease anxiety no differently than alcohol. It just suppresses the general GABAergic output, but it does it through the opioid pathway. And so when you do that, temporarily you can feel better, and that's why when we talked about yesterday, when we talk about adding value, if you have a lot of anxiety and you take an opioid and it decreases that anxiety, you now bestow a lot more value on that opioid. Your brain's like, that's valuable for me because it took away my anxiety. And then it starts to be your default behavior, meaning that every time you have anxiety, you take an opioid. And so then you flip into this other part of the brain called the lateral halvingula, which is for your basically default behavior. And then it also messes with dopamine. So we have all of these things going on that create the habituation, the value judgments, and the low dopamine and craving piece. This also happens for benzodiazepines. When we use that consistently, we find that the higher potency ones like alprazolam or Xanax are particularly difficult. All of that, however, long-term use of marijuana, long-term use of benzodiazepines actually increase anxiety over time. So if I have a patient who are on benzodiazepines for more than 9 months, generally speaking more than a year, but 9 months is what the literature says, is it takes me about that long to wean them off of the benzodiazepine without them having overt panic disorder. It takes a long time. You just got to go slow. It's about kind of 10% per month is kind of the general pathway until you wean them off. Generally, you want to start an SSRI or an SNRI while you're in the process of weaning, and a lot of mindfulness-based cognitive therapy, to go with that. The use of marijuana. If somebody uses marijuana and they have a generalized anxiety disorder, it will initially decrease it, because all of the intoxicating agents will decrease it until dopamine re-levels out and they no longer get that intoxication effect. And then the body's already compensated for it, and now it causes more anxiety. And then they get into that same cycle that we see with nicotine, which is, well, if I don't smoke, I get anxious. Or when I get anxious, I smoke. Well, you're anxious because you're withdrawing from your nicotine. It's not the treatment of your anxiety, it's that. So it's that same general pathway. And the question always comes is, what comes first? Right? What do we do first? Do we treat the co-occurring disorder and then we get to the addiction? Or do we get to the addiction and then we treat the co-occurring? I'll give you a little more data. So we looked at 600 patients who came into our clinic, and of those 600 patients, we looked at those that had mental health diagnoses, like hard DSM-5 diagnoses, typically in the bipolar, schizoaffective, schizophrenia pathway. And when we looked at that, what we identified is when we did a deep dive on it, we found all their records and pulled it in. Less than, so 44%, I'm trying to think back 5 years ago for numbers, but 44% of those patients actually had the diagnosis listed, which means most of those patients did not have that diagnosis. Most of those patients didn't have anything close to it because they had a substance use disorder and they were psychotic because they were intoxicated on cocaine or methamphetamine, or they were depressed because they were drinking alcohol and using benzodiazepines, or they were smoking marijuana and so they had a psychotic episode because they couldn't find marijuana, so they took K2 and they had a psychotic break. So these are all things that we find for the co-occurring piece. So what I find is that unless the co-occurring disorder is the most dangerous thing for them at that point, meaning they are floridly psychotic and they need to have medication, stabilization, and inpatient, then you should definitely aggressively stabilize the addiction while you're monitoring the co-occurring disorder. The reason being is because it's hard to come up with a solid diagnosis of a co-occurring disorder unless we've stabilized the use disorder for at least a little bit of time to see if those behaviors are still present when we do it. Now, that changes if you find out that somebody's been schizoaffective since they were 17 and they've always had these thoughts and these intrusions and they've always had visual hallucinations or auditory hallucinations, and then they started using drugs, then at that point you treat them in parallel. And so as we start to identify what we do with those patients, the main difference, and you guys are in the same situation I was in. So I was in a city with a bunch of psychiatrists, but none of them wanted to see my patients. Which is about like what you're in. You're in a city with one, right? And maybe not even one forever. I think that at this point you may be stuck with, telephonic. Well, I will tell you that telepsych can be helpful, but it's not terribly helpful with patients with disordered thought and addiction because they haven't built a relationship to be able to look through the normal behaviors of an addicted patient when the default in early unstable addiction is there's a little bit of a truth gap many times in the way in which the conversation goes. And that's a fight or flight response that they have. It's not like a nefarious pathway that they have. They're worried, they're scared, they don't want to do this, but that's a pretty common early identification when I see patients. The first 5 things that my patients would say to me were not really truthful. And that's pretty common. It's just a part of the behavior and a part of the predictable aspect of the disease. It's not just the pathology. Because that's how they survive. That's how they kind of work through that whole process. And then they come here, and then once you understand the disease, then you can let them say what they're going to say. And once they're done, you can be like, that was pretty good. All right, that was awesome. Now let's get to down what we're going to talk about here. Because I'm pretty sure that's not it. I'm cool with it. I mean, I recognize it. And if that's what really happened, then I apologize for saying this. But I feel like I've done this enough that we're okay to be able to have this conversation. I'm not going to fire you. We don't fire anybody. Which, that's the only way you actually get it. The difference between the co-occurring disorders, by the way, is if a patient feels safe, they're going to finally actually let you know what's going on inside their head. If they don't feel safe, you're never going to get to the bottom. And they only feel safe when they know you're not going to abandon them like everybody else in their life. So if you don't ever fire anybody, and we did 5 years of seeing most, everybody's been fired from, I had one person who was almost fired from our entire system because of his, creepy interaction. I think he maybe had somebody in the basement. I mean, he was a little weird, but at the same time, it was super creepy. But at the same time, he kept showing up for appointments because he knew he could come here and we would see him with where he is and we would have this conversation and we would work through it. And so we never fired anybody, which freaks people out. Well, what do you mean? What do you do? I'm like, well, I just didn't treat them. Well, what if they don't do what you say? I'm like, well, I'm not the cops. They don't have to. My job is not to tell them what to do, it's to give them the options of things that they can do and the risk and benefit of each of those, and we make a decision for it. And if they don't want to do it, I'm not going to malign them for not wanting to do it. And well, what if they sign a contract and they break a contract? And I'm like, well, the last time I checked, somebody's not going to miraculously not have addiction because they signed a contract. Somebody's not going to miraculously not see pain relief if they signed a contract and they're not having their pain adequately treated. I'm pretty sure that we don't make diabetics sign contracts that say no Krispy Kremes. right? And we don't fire them when they come in and their blood sugar's 400. I'm like, you're out. Obviously, you don't care about your, recovery of diabetes. We don't do that. So, and we took it to an extreme, right? I had one of my patients, one day it's Michigan, so it's snowing, right? I'm walking out to my car, got to stay late. My car's covered with snow, and I have like a hood on, and I'm walking out, and I'm about to open my door, and I get pushed from the back, and I kind of swing around, and I knock this guy down, and I look down, and it's one of my patients, and I'm like, what the hell are you doing? And he's like, Doc, I didn't know it was you. And I was like, does it matter? Are you trying to rob me? I will see you at 8 o'clock in the morning. And he showed up at 8 o'clock, head down, tail tucked. And then, I had patients that would fire us. They always came back. They would always came back. And when they if they said something to my front desk staff that was disrespectful, I made them apologize. I would walk out in front and see that behavior as a symptom that we needed to address. And we addressed it in a dialectical behavioral therapeutic way. If that's not okay, we correct the behavior. We do it in a substantive direct way. And then we let them sit out there or come back. Because if the behavior is uncontrollable, they're sick. And we need to see them. And we need to get them in faster than somebody else whose behavior is fully controlled. It's triage. And so you just have to kind of change the frame. Yeah.
Yeah, so I think you're answering my question, but in regards to prescribing MAT, what does the data suggest about mandating or not mandating enrollment in some sort of therapy or counseling for opioid use?
So the question is what does the data show about mandating that somebody get behavioral therapy in order to obtain MAT? I would say we just have to separate these things. And the reason being is the data does show there's a subpopulation that gets no positive benefit when you add therapy to the medication. It's not the population I saw. The population I saw all needed therapy, including the people delivering it. So, at the end, we really needed to be aggressive about, because they all had trauma, they all had this, but we only saw severe patients. But in most places, especially in primary care, you're not always going to see just severe patients. You're going to have a spectrum of people. And people that are sitting on this part of the disordered spectrum, they don't necessarily need heavy behavioral therapy, or maybe they're not ready for it. It shouldn't negate their access to a medication that decreases their chances of death by 60%. So when we talk about where it is, what I do for those patients is I say, if you don't want behavioral therapy, I think you need it. I really do. I think you would benefit from it. But if you don't want to do it, then I need you to see me more often. And we can have a medication visit, and I'm not going to do direct therapy, but I want to check in on you and make sure you're safe. Or you can just go to the therapy visit and not have to come see me. So you can make the choice, whichever one you want. Most of them would choose just the medication visit. Everybody would say, well, neither. And I'm like, that's not the choice I offered. So as we start to look, but now we have other things we can offer. We have long-term implants. We have injectable medications that last for a month. We have all kinds of versions of buprenorphine that we can give that take away some of this need the prescription kind of pill for the problem feeling that we have. So we have other modalities. But generally speaking, the data is pretty clear that you do not have to mandate behavioral therapy. In fact, if somebody goes to behavioral therapy and they don't want to be there, it doesn't work. Now, the thing that you can do that does work in that setting is motivational interviewing and trauma-informed care. Meeting them where they are, recognizing that they're in a space that it's uncomfortable, that they want to get well, and you use motivational interviewing. Anybody here certified in motivational interviewing? Everybody should get certified in motivational interviewing, even if you don't treat patients. This stuff is like the frickin' force. I am telling you, I can make people just... These are not the druids you're looking at. I swear to God, it is amazing. And it's not frilly. It's really science. It's very mathematic and tactical. There's very specific ways in which you can rotate an argument. There's specific ways that you can dig in a little bit and let them give you more information. There are ways that you move them through this trans-theoretical model of change, which goes from pre-contemplation to contemplation to preparation to action to maintenance. If they're sitting around in pre-contemplation and they have a high risk of death, we should not be saying they'll come back when they're ready. We should be saying, I need you to be ready. Here's what we can talk about to get you there. And you need to offer a space for them to be unstable but still be seen. And so there are no data that shows that a contract changes behavior, except in people that you didn't need a contract for anyway. So as we start to look at this, the sicker somebody is, the less likely a contract is to build a bridge, and more likely it is to build a barrier. So I don't advocate for those. I recognize they're in a lot of the CDC guidelines and things like that, but if you look at the references they give you, it's a big fat 0. So just be aware that the thing that makes the biggest difference is the relationship that you build with the patient and the fact that you got their back. Now, maybe they're misutilizing the medication, which gets to our current, one of the other questions, which is when do you know to stop? Because if you're in this business because you actually like people, and you want to help people, and you want to make them feel better. And so we have a tendency to let ourselves slide a little bit into enabling. It's a pretty common theme. We don't even really recognize it unless, again, we hold each other accountable. So we'll say, well, I don't want to stop medication because, I mean, if I do, they're not going to come in, I'm not going to be able to see them. But yet, they're negative for buprenorphine every time in their urine, and they're not on withdrawal, which means they didn't just run out early and show up. It usually means that they're diverting it, they're not really taking it, and they're positive for other drugs. We're not really doing them any good by perpetuating their ability to buy their other drugs of choice. So when patients are on a medication-assisted treatment and they have no other form of income, and yet they can afford to buy cocaine, I know where they're getting the money to buy cocaine. It is from my prescription. And so we have to make sure that we're aware of that reality. We just have that conversation. And I always tell the patients, there are 3 reasons people have urine drug screens which are negative for buprenorphine who are supposed to be positive for it. 1, you overtake the medication. Because you're scared, you need it, you overtake it, and maybe we need to increase the dose or think about a different pathway. 2, you're stockpiling it because you're scared that you may be without it, because I may fire you, which is not going to happen in our place, but in some places that may be the case. They want to stockpile it, so they run out a little early, but they're willing to hold on to it so that they have some extras that are there. And then 3, you're selling it. That's it. And I say selling no differently than if somebody's taking it. Because we have 3 things that we have to think about as people working in this with medication-assisted treatment: the safety of the patient, the safety of the household, and the safety of the community. And if we can't really make sure that we're maintaining the perspective of all of those things, then we shouldn't be writing it. And we have to have that conversation very clearly with the person you're writing it for. And I say it just like that. That's why I make sure they all have a lockbox. That's why I make sure that we do random counts. That's why I make sure that we had a cell phone in our clinic and I would make them take pictures of their meds for rapid pill counts. So that they didn't have a chance to go and rent medication to bring it in so that we could do a pill count. Which, by the way, there's a pretty good market for that. So people would be like, what do you need? I need strips. What dose? 8s. Fine. Here you go. And they'll rent it, and then they'll go in for their pill count the day later because they know they have their appointment, and then they'll do it. So we have to circumvent that with some other things and say, I'd like you to take a picture of all the medications you have. And they just know that that's coming at some point, so that acts as that contingency management strategy. But if all of those things are not happening, and the person is still using either opioids while they're getting buprenorphine, or they're not taking it and they're just selling it and using other things, we need to rotate the treatment. It just means that this treatment didn't work. We do this all the time for other things, right? We start somebody on a med for blood pressure, doesn't work. We raise the dose, maybe it doesn't work, then we just switch to another one. In fact, if your blood pressure is 220 over 120 and I still keep you on the same med, that's kind of malpractice. So we need to think about this in the same way, is that if we have a patient who's really floundering despite our best efforts to increase the dose of a medication or continue them on MAT and they just can't do it, it's not that they're failing, it's just that that modality of treatment is not working appropriately for them. And either they need a higher level of care or they need a different pathway of treatment. Some patients may need naltrexone, some people may need Vivitrol. It lasts for 30 days, blocks opioids, works very differently. And some people it becomes really, whoa, that worked. Other people, it's catastrophic and it makes it not work at all and they just start using some other substance to overcome the dopamine need that they have. Maybe they need methadone. If you don't have methadone, then what you have to look at is no MAT plus an increase in the other treatments. Because if it's not working, it's not working. So I can't really say for sure that if I have a patient who's very unstable, who we've increased the dose, that is still using other drugs, that is still having all these disordered behaviors, I don't think I'm increasing their chances of death by taking away the medication. I might actually be decreasing it because they'll no longer have the means to buy the other drugs. And just having that very open conversation with the patients too. I didn't do this. We have that conversation. You go, look, I'm scared. This is what I've seen. This is where we are. What do we do? What do you want me to do? I mean, I can't do anything else. I'm kind of stuck. I want you to be better. I'm scared for you. I'm worried for you. But if I write you this medication, it's not helping you. And you're going to tell me it's helping you, and you're going to try better next time, but we've had that conversation 5 times. And I can't do this anymore. So what is our plan? And here are the choices. I usually give them 3 basic choices. And they take them or leave them. And if they leave them, they fire you. You don't fire them. And in 30 days, they either die or come back. That was what I saw. And that was an unfortunate reality. This is a high mortality rate disease. But we shouldn't necessarily enable the behaviors that really aren't going to change the mortality rate, even if we had the medication. The medication works in the people that it's working for. So if I give it to people and it stabilizes their dopamine, it decreases craving, it stabilizes their behaviors, and now they're in remission, it worked. Great. In most people, it does that. In some people, it does not. Just like some blood pressure medications don't work for some patients. Sometimes they don't. These are patients who generally we have to try to remove from the location, try better stabilizing behaviors, or really dig in on co-occurring. This is the important aspect of co-occurring, is many times when they're unstable from addiction, we're missing a co-occurring disorder that we just haven't really stabilized and treated.
So for clients that you're seeing that are selling it or converting it, what about the idea of maybe the physician might come in daily at first, they come in once a week and you watch them take their prescription and see how they progress in action. Because I feel like a lot of the clients that I see at work when they take prescribed, oh yeah, I'm actually taking it. I'm not sure if they ever took it. They got it, they left, and then they went converted. So who even knows?
Right, so the question is can't you just change the modality that you're delivering the medication in, and whether that be making it where they come in and you visualize them taking the medication so you can see it. So here's the basic structure. So yes is the answer. That is one pathway that you can do. First you want to do, and I think it was also talked about the speaker before me, you really want to dig in and get a good tox screen. Because you want to find out what's in there. Because if they're negative for buprenorphine and they're negative for opioids, you got to find out what's going on. Because generally speaking, they're going to be positive for tramadol or fentanyl or things that won't show up on your standard drug screen. So you need to get a GC mass spec, like the big confirmatory test, to find out where you are. Because that way you have to make sure that you're not going to give them the medication to precipitate withdrawal. Because they have fentanyl or tramadol in their system and they're not telling you, and then you give them buprenorphine and observed dosing, and then they're throwing up and having diarrhea in your office, which is not fun for anybody. And so that's kind of step one for the process. And then you offer that to them. The only way that I'm going to give you the medication is if you come in and you take it in front of me on a daily basis. It doesn't work that well in an office, to be honest, to structurally set that up. So what we did is we identified a local pharmacy and we wrote it so that they could daily dispense the medication at the pharmacy. And that the pharmacist would actually watch and take it. So pharmacy, I think, has an understated role in this, and we can really add to their capacity by doing this. You generally, they need to be on board, they need to be a part of the team, we need to, all of those things. But I think they have a big role to play. And so as you go there, you can do that. So that's probably the easiest way to make that happen. And then they watch them take it and they go from there. Definitely can do that. And then some people that'll work and some people it'll fail. But we should try, right? You got to pull the rabbits out of the hat sometimes. You got to really try some stuff, that doesn't necessarily work consistently, but I'm willing to come up with a new pathway for you. And honestly, when you ask them, they don't want to be sick. They're freaking out. They're really concerned that they can't get stable. And it gets into kind of this shame cycle as well, where maybe I'm lost, maybe I'm done. Which, remember, I talked about kind of this difference between what takes you from the acute version of addiction to the chronic version of addiction, and the chronic version of addiction to suicidality. It's hope, or hopelessness. So if you have an acute version and you have hope, you're more likely to not actually convert to the chronic version. If you have the chronic version of addiction and you have hope, you're more likely to keep trying, right? If you're hopeless, you're more likely to actually kill yourself. Because we really don't know what portion of people that died of a drug overdose was intentional. I think it's probably a lot. It wouldn't surprise me if it's half. And we don't really know, because we don't do a lot of digging into where people are mentally on this, which comes with the co-occurring, is we're not doing good suicide-based assessments on patients. And because of that, we're missing some stuff. The problem is that there are no validated suicide assessments in patients who are actively addicted. They're all in patients with just behavioral depression. So this is really problematic. Yeah. So these are great questions. So the first question is, are there any safety concerns of giving somebody buprenorphine while they're still using methamphetamine? Short answer is no, not really. They don't really interact in the same cycle pathway, except in the central aspect. So in theory, because you're on buprenorphine, if you take methamphetamine, you may actually need less methamphetamine to get intoxicated, because it can be a boosting agent if you take stuff on top of it, right? So if people are on buprenorphine and they're smoking a bunch of weed, they're stoned. I mean, they actually can smoke less weed and get high. So when you're taking other illicit substances that work in that same dopamine pathway, they're still pinging the dopamine pathway in a pathological way. So that's the one piece. What was the other piece again? Sorry. Oh, protective for overdose. So I wrote an article on the pathophysiology of pharmacology of buprenorphine, and never got more like hate mail from ER doctors. It was all accurate. They weren't actually pushing against the accuracy of it. It was a thought process. If I have a patient who accidentally has fentanyl or Norco in their system, and I give them buprenorphine, it puts them into precipitated withdrawal, right? In theory, if I have a person who's overdosed on heroin and I don't have Narcan, I can give them buprenorphine and it will wake them up because it will cause precipitated withdrawal. Because it binds to the receptor more tightly and it has a higher affinity, which means it turns up the signal from that receptor higher. So if it is on board at a therapeutic level, it will be really hard for other drugs to be as effective because it's blocked by the buprenorphine molecule that binds it more tightly and it won't kick it off, even if it has this higher ability to turn up the noise a little bit. So it is protective from overdose from what we can identify. Obviously we haven't done, there's a couple of animal studies that I may be doing at U of M. I'm just getting on staff there because I just moved to Ann Arbor a year ago. And as I get into that, I've identified some basic science studies. This is actually one of them because I want to identify how protective is it for different classes of opioids. And the first place that you need to start is an animal model. So we'll need to figure out kind of what that looks like from there. But right now, none of those studies are out there from it. From my patients, I actually learned a ton from my patients who are now stable, even those that are not stable. They will tell me that it takes more heroin to get high if you're on buprenorphine than not. So that tells me that it's going to be protective at some level. But that's the best I got for it. I don't have a good study for it. And then, yeah. So, yeah.
I think our is specific for our program dedicates somehow to the results of their theory just to get prior to the test. You know what else I actually research results.
Yeah, so the question is if we do a toxicological study, can you determine if they're taking their buprenorphine appropriately from that toxicological study? And the short answer is, from one study, absolutely not. Those are toxicology companies overstating their capability, period. Because a one-time drop, you don't know how they metabolize it, you don't know when they took it, you don't know what their normal time of day of taking it is, you don't know if it absorbed better that time because they drank some stuff before it or after it. I mean, it's sublingually, there's so many variables about the dose that they get on a regular basis because the bioavailability is really not that good and it has to sit in the mouth for a little bit. If you swallow, if your mouth is dry, if you have all of these things, it really confounds what that looks like. We also just don't know about the metabolites. We don't have good binding data on what it does for people with high protein or low protein. We don't have good data on other drugs that it may bind and actually push it out. The best thing to look for is the presence or absence of norbuprenorphine. So the interesting thing is if they're using other opioids and they took it right before they showed up, they would be in withdrawal. And so the other piece is that if they are negative for norbuprenorphine, then that means one of two things. They just took it, or they just tore off a piece and put it into the urine so that it would be positive for buprenorphine. So that's why you always do the study to look at buprenorphine and norbuprenorphine, which is the first major metabolite. Yeah, and when you look at those two, that will tell you whether or not it's being taken and metabolized. And that's really helpful for those two reasons. Because if it's negative, there's two reasons. One is they put it in the cup and they didn't do it, or they're on the last leg and it's negative for both, like they're just trying to get through and it missed the cutoff. So sometimes the threshold, you got to know where the threshold is on your test, because just because it's negative on your test doesn't mean it's negative. It just means that they have just enough to keep them from going into profound withdrawal. or they took it right before they came in, or they spiked their urine. So those are kind of the three pieces, but generally, especially for oral fluid testing, you definitely can't use oral fluid testing to determine if they're taking it properly and each at the right dose at the right time. Yeah, go ahead.
What about for patients who abruptly want to stop alcohol and opioid use simultaneously? Do you use benzodiazepine together or restrict?
Yeah, so for patients who want to stop alcohol and opioid use at the same time. So in the fall, we're coming out with the brand new alcohol withdrawal treatment guidelines. So I'm on that guideline committee, and we'll have outpatient and inpatient treatment guidelines that allow you to know which version. If you're coming off of opioids, you can benzo load and go with carbamazepine or valproic acid, or you can just go with carbamazepine. We have enough data now to say that we don't even need a benzo, where we can just start with carbamazepine or valproic acid and maybe add some clonidine to help with the withdrawal symptoms for the opioids. But typically, you should never have to withdraw from opioids if you start them on buprenorphine or methadone. But for here, it would be buprenorphine, because you fix with they don't ever have to go into withdrawal. You just treat it with bupe, and then all you're dealing with then is alcohol withdrawal. And you would need less medication if they're on bupe, if you do that. So that's the general. There was a question over here earlier. Did I miss it?
I was going to ask the
Yeah.
medication system regarding alcohol.
Yeah, so if a person has an alcohol use disorder and an opioid use disorder, buprenorphine is never my first line treatment. Naltrexone is my first line treatment. It's FDA approved for both. It works really well. It's super low risk. I start with that because it's indicated for both and has no risk on either side. Putting somebody on buprenorphine and while they're drinking, it's unpredictable. It's probably low likelihood because remember, they've already been taking opioids. So if you just look at it pragmatically, buprenorphine is safer than the other stuff they were taking for risk of respiratory suppression. So if we change that for buprenorphine and they continue the same amount of drinking, then we're safe. There's no problem. But what happens is many times they increase their drinking because they no longer have this other opioid. And so we have to predict that this person is going to increase the other sedative intake. And when they increase the other sedative intake, that's when it becomes really dangerous, which is why I like to do this. If they meet criteria, which most of them do for a level 3.5 withdrawal management, if they meet for that, then I'll put them inpatient, and then we can really do the switcheroo while they're there once we're working on getting alcohol out, and we can decide injectable long-term naltrexone versus buprenorphine.
So abstinence increases risk of death from overdose. What is the relapse of buprenorphine treatment?
Yeah, so the risk of death if they relapse while on buprenorphine treatment, does it increase, decrease, or not change their risk of death? No good data on this, but theoretically speaking, it would decrease their chances if it's still in their system, obviously because it would block. If it, however, is fully metabolized out and no longer there, you haven't really changed their tolerance that much. Now, if they were on naltrexone, then that has a theoretical risk of accidental overdose because it in theory lowers your threshold. It's never been borne out in the literature though. It's good theory, it's logical, it makes sense, but I haven't seen a publication that really shows it. And so the biggest problem is that if they've been stable for a while and in remission and on medication assisted treatment and they relapse, they generally haven't maintained a drug dealer relationship. They don't, so they don't know what's in it. So when they had back in the day, the biggest risk is they actually knew who they were buying it from generally, and they kind of knew what was in it, and they could trust what was in it. If they haven't used for a long time and they've been out of that circle and they bounce back, they may end up getting it from somebody they don't know. And that's where the risk comes, because they don't know if it's going to be 85% heroin with a little fentanyl or 35% heroin with no fentanyl. And generally, if they're that reactive and that emotional for that relapse phase, generally speaking, they're not walking through I should partial dose just to test. I mean, it's just the reality of what happens. People who are active in their disease and kind of the maintenance phase of heroin use disorder, they can be thoughtful that way. They'll split dose a new dealer. They'll do a tester dose and they'll talk around and they'll walk through it. But a person who's been stable and in remission who relapses, there's usually a significant thing that happened for that relapse to happen. And so with that, they're a lot more reactive and emotionally heterogeneous in that moment. And so they're less likely to have a lot of thought around it. And that's more risky than I think any of the other meds that we're using and how we're using it.